So the neoplasia is an irreversible change that must take place within the cells, and it's passed on to the new cells. And again, it's uncontrolled cell multiplication, and it is an abnormal process. But again, it's not necessarily cancerous. So many things can cause a neoplastic transformation of cells. Chemicals, viruses, the sunlight, radiation, things like that, or it can just happen due to a mutation. The classification of tumors, as we know, benign tumors are the kind we want if we're going to have a tumor. That means that it's localized, it's usually encapsulated, it's not going to invade tissue around it, but it can have the ability to spread, but it's not cancerous or malignant. So malignant is the term that we give to a tumor that can invade and destroy surrounding tissue, has the ability to spread throughout the body. So when you hear someone talk about metastasizing or metastasis, that is a malignant tumor that has spread throughout the body to other parts of the body. Benign tumors almost always are going to resemble the tissue that they're found within. So they're going to look really similar to the normal tissue that's there, just a proliferation of that tissue. Malignant tumors will vary in their histologic appearance, so sometimes they're well differentiated. They'll have neoplastic cells that do resemble the normal cells, or they can have poorly differentiated cells that don't resemble the tissue that they're found within. But malignant, they're that's why they always tell people to be looking for, changes. Is it got an irregular border? Is it abnormal? Those kinds of things would indicate a malignancy. Pleomorphic just means cells of different sizes and shape, and hyperchromatic are cells that are darker. This isn't anything that I really hit on heavily. The names of tumors are important. So usually when they're naming a tumor, they're going to think about the tissue of origin and then whether it's benign or malignant. Most of the time, if a tumor is an oma only, like a papilloma, an adenoma, a fibroma, osteoma, lipoma, those are benign. Usually if something is cancerous, you will see carcinoma or sarcoma in the name. There are, if you look at this chart, a couple of exceptions to that rule. One of them is melanoma. As we know, melanoma is a very malignant, bad prognosis in many cases, cancer. So lymphoma and melanoma are the two omas that are cancerous that I can think of right off the top of my head. But if you look at this chart, the tumors are named by their tissue of origin and then whether they're benign or malignant. So a squamous cell is squamous cell carcinoma, or they might call it epidermoid carcinoma. Basal cell carcinoma, as you can see, that one is different too because they have it under benign, because basal cell carcinoma is the best, probably the best. If you have to have a skin cancer, basal cell is the least threatening to the patient. But it is a carcinoma in the benign category because of that reason. And I'm not sure why this chart is like that, but basal cell carcinoma is really non-life threatening. Squamous cell can be more invasive, and as we know, melanoma is the worst. So just kind of look through this chart, familiarize yourself. For the most part, we can follow the rule that if it has carcinoma or sarcoma in the name, it is malignant, and benign tumors most of the time are just omas. And this is repeating what I just said. So treatment of tumors, whether I have a benign or malignant tumor, there's usually treatment of choice. Benign tumors, 9 times out of 10, are just surgically excised and possibly enucleated. What enucleated means is they'll go into the area where the tumor was and kind of scrape it out. They want to clean out all that tissue. They want to make sure they get all of those borders and leave a nice clean space. So that is for a benign tumor. Now with a malignant tumor, they're going to go in, possibly have to use surgery for removal, depending on how many organs are involved or how many areas are involved. Then they're going to use chemotherapy, possibly afterwards, to try to kill off the cancer cells, or radiation therapy, or a combination of both. So malignant tumors obviously are treated more aggressively. Benign tumors typically can be excised, they'll biopsy them, and then we move on. There are 3 different types of epithelial tumors in the oral cavity. So squamous epithelium. We also have salivary gland epithelium and odontogenic epithelium. And so the tumors that we'll see in the oral cavity from squamous epithelium, this starts on page 221, are the papilloma, premalignant lesions, squamous cell carcinoma, verrucous carcinoma, and basal cell carcinoma. So we'll talk about each of those. Papilloma is pretty common. I saw these quite often. It's a benign tumor of that tissue, and it kind of hangs out like a cluster of teeny tiny grapes. So it's pedunculated most of the time. The ones I saw were, they don't have to be, they can be sessile, but a lot of times they're on a little stem. And they've got, you can see when you look in this at this image, there's little tiny round, they look like little grapes, or like a little head of cauliflower. They can be white, or they could be the color of the tissue, and they're most commonly seen on the soft palate or the tongue. So that's probably one of the main things you want to know about papillomas is, number one, they're benign, and where we see them the most common, and that's the soft palate or the tongue. And if you look at this, this is what it looks like if you took it and sliced it in half and looked at it microscopically. I think it looks like a little head of cauliflower, but it's got all those little papillary projections with that center core. And what do we do for this? We remove them. Some premalignant lesions. We've talked about leukoplakia, erythroplakia, and we haven't really covered epithelial dysplasia yet. So we're going to talk about that. Leukoplakia is what we're going to give a lesion that hasn't been biopsied yet. We don't know what it is, but it's a white lesion. It does not wipe off. And most of the time, those are due to hyperkeratosis, due to a repeated habit that causes kind of that callousing or hyperkeratinized tissue. Or it could be epithelial hyperplasia. And hyperplasia is an increase in the number of cells. So it's whatever is irritating it is causing those cells to proliferate. Or that says hyperkeratosis again. So microscopically, if we looked at this leukoplakia, microscopically we could see epithelial dysplasia. And what epithelial dysplasia means is that those cells are dysplastic. They're abnormal. The way the cells look is not normal. They look different than other cells, which can be a premalignant condition, or it could even be the precursor to squamous cell carcinoma. So that's why leukoplakia, we want to, if we think it's frictional hyperkeratosis or something like that, we would like to have that patient remove whatever habit they're doing and then have them return in a couple of weeks to see if that has corrected itself. If not, we're going to send it for biopsy. So erythroplakia now is a red lesion, and I've probably mentioned this, but I'm going to say it again. Red lesions in the oral cavity are more concerning. Not that we need to pay less attention to white ones, but more concerning in that I believe 90 to 95% of them end up being some sort of cancer. So if we see an oral mucosal lesion that is a smooth red patch or even grainy and velvety. They can even be a mixture of red and white. These erythroplakic lesions are often found on the floor of the mouth, the tongue, and the soft palate. They are less common than leukoplakia. So we want to definitely make note of those red lesions. We want to send that person, if we can't attribute it to something like, a burn, or they cut them or hurt themselves in some way, if they can tell you through a historical diagnosis something that's happened, then great, we'll have them back in a couple weeks and check it. If not, and they're unaware of it, we're going to send them for biopsy. Chronic oral mucosal lesions that can be associated with betel kid or areca nut chewing. I don't know if you guys have ever heard of that, but there are certain cultures that chew on betel leaves. This can lead to this oral submucosal fibrosis. And it kind of is almost like a callousing of the tissue because it's being irritated by this betel nut that they chew on all the time, which causes an increased deposition of collagen in that mucosa, which can severely restrict the movement of their oral mucosa tissue. So anything that becomes fibrotic becomes kind of stiff and it no longer moves like it should. We discussed how leukoplakia could actually become, could be epithelial dysplasia, and what that is, again, can be a pre-malignant condition. So it would show a disordered growth of cells. And oftentimes when we start to see this epithelial dysplasia, that is preceding squamous cell carcinoma. So, people that chew tobacco, we see the white lesion, we send them for biopsy, they tell them it's dysplastic. That's a real good time to stop that habit. At the very least, if they're holding it in the same place all the time, we want to move it so that that tissue can have a chance to recover. Many of these changes that we see can revert back to normal tissue if they remove the irritant. Okay, that's again what we were talking about. The one thing on this I want you to know is carcinoma in situ. Carcinoma in situ, if you were to see a picture of that, which I do believe we have on, it looks pretty ugly. I'm looking here in your book. I was thinking that one of the images on page 224 was that, but carcinoma in situ looks angry and bad. It is severe dysplasia that is involving the full thickness of epithelium. At this point, though, it's still kind of salvageable. It's at a point where we could hopefully excise and remove the bad habit and hopefully not see this progress into a malignant condition that can't be reversed. So carcinoma in situ is severe dysplasia. And then the next step is squamous cell. So squamous cell carcinoma is what we would like to prevent if we could. This is a malignant tumor of the squamous epithelium. It is the most common primary malignancy in oral cavity. It definitely can infiltrate other tissues and form metastasis in other distant places. And the first place, because it's so close, it usually metastasizes to our lymph nodes in our neck. And as we know, lymph then can go out all over your body. Lymph fluid and everything goes everywhere. So we definitely would like to prevent that. We want to make sure that it does not get to those areas. But it could then go to distant sites, even like the lungs and the liver. And usually squamous cell carcinoma is going to be an exophytic, meaning that it sticks outward, ulcerative mass. And it can, like if you were to take an x-ray, you would see, if it was allowed to progress, that it infiltrates and actually destroys the bone underlying it. So here we can see the pictures that are on page 224. A is squamous cell carcinoma that we see on the posterior tongue. The floor of the mouth and the posterior tongue are very common locations for squamous cell. The left side of the soft palate is what we're seeing in the image on the upper right in image B. And then carcinoma on the floor of the mouth, squamous cell, is C. And then that's a radiographic appearance of someone that had a lesion and it has completely destroyed the underlying bone. So squamous cell carcinoma can invade the connective tissue that underlies that, which then affects that basement membrane. And that's where carcinoma in situ does not include the basement membrane yet. So once it becomes squamous cell carcinoma, the basement membrane has been invaded, and it could travel at that point to lymph nodes, liver, lungs. So that's where we would like to catch it before this point. And we've already talked about the most common locations. You definitely want to know this about squamous cell carcinoma, so highlight this. Floor of the mouth, the ventrolateral side of the tongue, soft palate, tonsillar pillar, and retromolar areas. If squamous cell carcinoma, it can affect the vermilion border of the lips and of the skin and face. So if it's not inside the mouth and it's actually on the lips and the skin and the face, that's a better prognosis for squamous cell. The intraoral tends to be a worse case, worse scenario, but on the border of the lips and the face, sometimes it's a little bit better outcome for the patient. Solar cheilitis just means that's a condition it's due to sun exposure. So that's what we're seeing on the lips, where they start to lose that vermilion border and you no longer see a definite outline of their lips. You might see little white spots or brown spots, things like that. We would want that person to avoid sun exposure, use a sun blocking agent. We saw this so often in people that had worked like in farms or, for the telephone company outside on telephone poles all day long, people that are outside, construction workers. So risk factors for squamous cell. Tobacco, probably the #1 risk factor. Whether it's smoking a cigar, a cigarette, or a pipe, even snuff dipping, tobacco chewing. I feel like with the people that chew and snuff, anything that's put directly on the tissue like that tends to have a more rapid outcome, negative outcome. And then if alcohol consumption along with like if you combine these, that's a double whammy. And then the exposure to UV rays and human papillomavirus, if the patient has human papillomavirus in some form or fashion, that tends to lead to oropharyngeal cancers. It is associated with squamous cell carcinoma, so it definitely plays a role in this as well. So treatment, we're going to surgically excise that exophytic lesion, and then radiation therapy or chemotherapy may also be used. And because of that, we're treating the mouth, the area where our salivary glands are, they're going to suffer with xerostomia. You guys have probably heard if somebody has cancer, everyone, they'll say, what stage is it? It's called the TNM staging, can be used to determine the prognosis. And the higher the stage, as you know, the worse prognosis. So in your book, there is a table 7.3 on page 226 talks about the staging, and that is done by tumor size, number of lymph nodes affected, and has that cancer metastasized to any distant site in the body besides where we see it. So that is basically how it is staged. So if a tumor is a T1, it's less than 2 centimeters. If it is a T2, it's 2 to 4 centimeters. T3 is going to be larger than 4 centimeters, and T4 is a tumor that is invading adjacent structures. So when people say it says stage 4, that's the worst because that has invaded adjacent structures. Then obviously the more nodes involved, the worse that's going to be too. Are they N1 is ipsilateral. I don't know if you guys have heard that term, but ipsilateral means I'm feeling it on one side, but not the other, or seeing it on one side and not the other. Contralateral means they're on both sides. So bilaterally, I can feel those nodes. And then N3 is a fixed palpable node, meaning that it doesn't move. We like them if they're movable. We like them if they're not tender, those kinds of things. But if they don't move, that's kind of a bad sign. So that's kind of how they're staged. They look at the size of the tumor and are nodes involved, and is it one side or both sides? And then metastasis just means if it's MO, that's no metastasis, and if it's M1, that means that we have clinical or radiographic evidence of that cancer being somewhere else in the body. Another one of the epithelial cancers is verrucous carcinoma. And again, it's an exophytic growth, and it has kind of that pebbly white and red surface. This one is slow growing, which is good. With that one, those little projections that we see are keratin filled. Usually the epithelium is well differentiated. It doesn't have any atypical cells. It doesn't show invasion through that basement membrane, and we're just going to remove that by excision. Basal cell carcinoma, like I said, it is a malignant skin tumor. Remember they had it in the benign category in that chart that we were looking at? It is a malignant skin tumor that is associated with sun exposure. It just has a much better outcome. So it frequently is seen on the face. It appears like a non-healing little ulcer. It will have rolled borders sometimes. Sometimes it almost looks iridescent. It'll flake off, and a patient will think it's like a scab that they keep kind of flipping the skin off of, and it doesn't go away. Most of the time we see this in white adults. And it is microscopically basal cells derived from that squamous epithelium that are proliferating into that underneath that connective tissue. So what do? We remove it with excision. And if it's a large lesion, they may treat it with radiation. But luckily, this rarely metastasizes. So that is why they don't have it in that malignant category in that chart. But I think it makes it confusing sometimes because it is a malignant tumor. It's just not one that metastasizes very often. I'm going to skip through the objectives. Salivary gland tumors we'll touch on. There's the pleomorphic adenoma, which is the most common salivary gland tumor. Monomorphic adenoma, adenoid cystic carcinoma. So now we're into the carcinomas, which would indicate malignancy. And then mucoepidermoid carcinoma. So again, salivary gland tumors can arise whether it's the major, like the parotid, or the little minor salivary glands. The minor salivary gland tumors are most often located at the junction of the hard and soft palate. And adenomas, remember, it's an oma. So that is the word that is put along with the salivary gland tissue, signifying that this is a benign tumor of the salivary glands. And in your book, under salivary gland tumors, if you turn to page 228, you can see there's one of the palate that we see on B. Yes. And that is a malignant adenoid cystic carcinoma. The one that we're seeing on the lip there is a benign salivary gland tumor of the upper lip, which is the upper right corner of your screen right now. And there is the one on the tongue, which is a malignant salivary gland tumor of the tongue. So those are adenoid cystic carcinoma. So the lip and the this other D is also malignant of the buccal mucosa. So you can see sometimes they look really ugly and you would just almost know right off the bat or think you know that it's malignant. And then sometimes they don't and they are. So when you find these kinds of things, it's so important to follow up on them and send them for a biopsy. The pleomorphic adenoma, like I said, is benign. And 90% of all salivary gland tumors are a pleomorphic adenoma. So it's the most common, and it's most commonly found extraoral in the parotid gland, and intraoral is the palate. So extraoral, you might see a swelling of that parotid gland. And intraoral, you're going to see a bump on the palate like you see in your book on A, upper left corner in your book. So clinically, it's going to appear as a slowly enlarging, it's not ulcerated, and it just looks like a mushy dome. You can kind of touch it and it's not painful to the patient. And to treat it, they're going to remove it with excision. Can recur. It just kind of depends on the success, how well they were able to remove it. Did they get it all or did they leave any of that behind? They have been known to undergo malignant transformation if they're not treated. So that's why it's very important for us to be on top of this and make sure that our patients go get these things seen to. A monomorphic adenoma occurs most often in women and in the upper lip and buccal mucosa. And it is benign and it is encapsulated. So we're just going to excise that and make sure we get all of that tissue. It can also be called a Warthin tumor. And a Warthin tumor is going to be found in epithelial and lymphoid tissue. Again, it's painless, it's soft, it's compressible, usually in the parotid gland, rarely intraorally. So we're probably going to see that more extraorally, and this one is predominant in men. Mucoepidermoid carcinoma is a malignant salivary gland tumor. So we've got carcinoma in the name now, and it's kind of telling you its tissues, mucoepidermoid. So major gland tumors are most often found in the parotid gland, minor gland tumors on the palate, and these are slowly enlarging masses. Again, it's a combination of those mucus cells mixed with squamous cell, and that's kind of where it gets its name. It can appear as a unilocular or multilocular radiolucency, and if you look at that radiograph that's pictured on the lower right of the screen, you can see how it is kind of multilocular. And we see both light and dark, like little bubbles. This occurs in many ages. We see it in adults, but it's most common salivary tumor in children that is malignant. So if you were asked what is the most common malignant salivary gland tumor in a child, it would be mucoepidermoid carcinoma. The most common malignant cancer in an adult, now this is just cancer, would be squamous cell carcinoma. That does not involve salivary gland. So you've got to kind of differentiate which ones are which. Again, with this, we're going to surgically excise this lesion. The other malignant salivary gland tumor is the adenoid cystic carcinoma. It is slow growing. All of these to this point have been slow growing. It can be major or minor salivary gland tissue. It can be ulcerated and painful. And again, the most common site for this one is the parotid gland. It looks like Swiss cheese under microscope. When they stain it, it looks like it has these epithelial cells that resemble Swiss cheese, and we're going to excise this lesion as well. Other salivary gland tumors that are malignant, we're not going to really talk about. They're listed there for you, but I'm just going to skip on. And now we're going to talk about odontogenic tumors. We've got epithelial odontogenic tumors, mesenchymal, mixed, and peripheral. There's a chart in your book again on page 231 that talks about and classifies these odontogenic tumors. There's the ameloblastoma, which you will hear about. We'll talk about that one. That one's fairly common, and that one I would expect to see on a board possibly. And then the others listed here, I'm looking through. You don't hear about them quite as much, but the ameloblastoma is mentioned quite often, so I would definitely highlight that one. These odontogenic tumors are derived from tooth-forming tissues. They can be composed of either epithelium, mesenchyme, or a combo, and most of them are benign, but rarely you can have a malignancy form. So the epithelial odontogenic tumors are the ameloblastoma, like I mentioned, the calcifying epithelial odontogenic tumor, the adenomatoid odontogenic tumor, and the calcifying odontogenic cyst. So the ameloblastoma, it is benign, it is slow growing, but it can be aggressive. If you look at that radiograph, look how much destruction we see in that bone where it's all radiolucent. This can occur either in the mandible or the maxilla. However, we see it most commonly in the posterior of the mandible, and it can infiltrate into surrounding tissues, causing quite a bit of damage. Radiographically, it's going to be that soap bubble appearance or honeycombed. It can occur anywhere in the jaw and is often associated with a dentigerous cyst. So remember, the dentigerous cyst is most commonly seen over an unerupted third molar, and a dentigerous cyst is a cyst that is only around the crown of an unerupted tooth. So it's commonly associated with that, this ameloblastoma. It can cause bone expansion in the jaw, and we're going to go in and surgically remove it, and unfortunately these reoccur quite often. The next one we'll talk about is the calcifying epithelial odontogenic tumor. This is a benign epithelial odontogenic tumor. So it's kind of got an amyloid-like material. We see some calcifications when we look at it microscopically. It most often affects adults. And radiographically, if you look at this, it's kind of unilocular, multilocular as well. It occurs more often in the mandible than the maxilla, just like the ameloblastoma, but it's most often seen in the bicuspid to molar area, where the ameloblastoma is, it can be anywhere, but it's more often seen way back in the posterior. And again, we're going to surgically excise this. The AOT is the adenomatoid odontogenic tumor, and it is an encapsulated benign tumor as well. 70% occur in females under the age of 20, and 70% involve the anterior portion of the jaw. So that makes this one stand out because we see it in young females and in the anterior part of the jaw, and it is more common in the maxilla. The other two were more common in the mandible. Many of these are associated with impacted teeth as well. It is surrounded by dense fibrous connective tissue. It has little duct-like structures and whorls. I'm not going to ask you about that. That's just for your entertainment and education to look at that. Okay, so radiographically, it's going to be a well-circumscribed radiolucency, and it can have radiopaque areas as well as those radiolucent areas. It does look like a follicular cyst. It definitely resembles that. The one thing that would be maybe an identifier is if they told you it was a young woman and they told you it was in the anterior part of the mouth. The most common location for a follicular cyst is around a third molar, an unerupted third molar. So those would be the kind of the differentiating factors. Again, with this tumor, they're going to enucleate it. So they're going to remove it, and then they're going to kind of go in and scoop the area out where it was and clean out all that tissue so that hopefully it can regenerate new fresh tissue and kind of fill in that area. The calcifying odontogenic cyst is a non-aggressive cystic lesion that's lined with, again, odontogenic epithelium. This one is seen in individuals under 40. Usually well-defined lesion, can be unilocular or multilocular like the others, and this one again could have some calcification. A lot of times if a lesion contains calcification, that might be indicative of the length of time the lesion has been present. Many times we see those calcifications the longer that lesion has been there. This one, the calcifying odontogenic cyst, has an association with these characteristic ghost cells, and it's just the way they're keratinized. They look like round structures that have that kind of clear center that makes them look ghost-like. And we're going to surgically enucleate the area of the cyst, so remove it, clean it out. And this one does not have a high reoccurrence rate. The mesenchymal odontogenic cells, or tumors, are the odontogenic myxoma, central cementifying and ossifying fibromas, and benign cementoblastoma. We'll talk about the odontogenic myxoma first. It is benign. It is non-encapsulated, which means if something's encapsulated, that means it's enclosed. This one's not enclosed, so it can infiltrate. Most of the time we see this in young people ages 10 to 29, boys or girls, and it's going to look multilocular or honeycombed with poorly defined margins. If you look at the x-ray on this slide, you can see that. It can become large, and this one can cause teeth to become displaced or to move, and again, it's most commonly seen in the mandible. So the identifiers for this one would be it occurs in people ages 10 to 29, and that it causes displacement of teeth, even though it's benign. We're going to surgically excise this. This one can reoccur. The central cementifying or central ossifying fibromas. Remember when we talked about giant cell granulomas, if they're central, they're within the bone. If they're peripheral, they're on the outside, okay? The periphery of your house is the outside of your house. So if something is peripheral, it's going to be soft tissue. If it's central, it's in the bone. So on this one, we've got a benign, well-circumscribed tumor, as you can see. Usually occurs in adults in their third to fourth decade, so 30 to 40 years old, most often females, and mandible again. It varies from radiolucent to radiopaque. If you look at that lesion, you can see some radiopacities in the center and some radiolucencies. It just depends on the amount of calcified tissue present. Treatment is going to be excision, and this one does not reoccur. The image that you see here, that one's got a lot of ossified or cementifying tissue where it's more radiopaque. A benign cementoblastoma, when we think cementum, we're going to think around the root. So this lesion is found around the root of a tooth. It is cementum producing, which it looks like cementum. It is a well-defined radiopaque mass with surrounding halo, radiolucent halo. They're going to go in and remove the tumor and possibly the tooth involved, because the tooth is kind of part of the tumor. So once they go in and remove the tumor, the tooth involved and everything, enucleate all that, then it does not have a high recurrence rate. The mixed odontogenic tumors are the ameloblastic fibroma, the ameloblastic fibroodontoma, and the odontoma. The ameloblastic fibroma is benign. Again, it's an OMA. It is non-encapsulated. It occurs in young children and adults, and more often in male. These are common in the mandibular bicuspid and molar region, so a little bit more anterior, unlike some of the ones we're seeing in the jaw. Radiographically, it is well defined sometimes, and then sometimes it's poorly defined, unilocular or multilocular, so it can appear pretty much any way, but we're going to see a radiolucency, and we're going to have to treat that with surgical excision, and when we do, there's a low reoccurrence rate. Ameloblastic fibroodontoma is benign as well, has features of the ameloblastic fibroma, and it has some features of an odontoma, which is the next one we're going to talk about. These again are young adults, average age is 10, and this one typically arises in the posterior jaw. Radiographically, it's a well delineated radiolucent or dark lesion. It can be unilocular or multilocular, and we do see calcifications within the radiolucency, which makes sense with the name. Think about your tissues. Fibrotic tissue versus odontoma. Odontogenic tissue is going to be tooth-forming tissue, so that's going to appear more radiopaque. So we'll see those calcifications within that radiolucency. This is going to be treated with surgical excision, and reoccurrence of this one is unusual. Here's an odontoma. We have a few patients that have these. This is a compound odontoma that you're looking at in this image, and a compound odontoma occurs in the anterior portion of the mouth, and it resembles a mass of little bitty teeth that started to form. When we see a complex odontoma, it looks to me, I'm going to see if I can find one for you. It would be found on page 237, figure 728. And to me, it looks more like a cotton ball. It's found in the posterior of the mandible, and it looks like a puff. It almost looks like dandelions when they go to seed and they turn into that white puff ball. That's what those complex odontomas look like to me. And then the compound are in the anterior, and they look like little clusters of teeth that started to form. Most of these are seen in adolescents and young adults. And what happens in the complex that you're looking at is there's a failure of the tooth to erupt. And so this odontoma forms over where that tooth needed to erupt, and it's unable to erupt through that. So they go in and they remove that complex odontoma. Peripheral odontogenic tumors. We've got the peripheral, so it's going to be on the outside, ossifying fibroma, and other peripheral odontogenic tumors. So peripheral is on the outside. I'm going to be able to see this by looking in the mouth. So it is a well-demarcated sessile or pedunculated. It can be flat or it can be on a stem. Most likely derived from cells of the periodontal ligament, they think, more common in women and young. It is composed of fibrous connective tissue mixed with bone and cementum-like calcifications, and they're going to surgically excise this. Tumors of soft tissue are lipoma, which we know that lipo is fat. We've got tumors of nerve tissue, tumors of muscle, and then we have vascular tumors. A lipoma, a lot of people get these. We'll see them in the mouth. We'll see them on people's skin, on their feet, wherever. It's just kind of a mass of squishy tissue, and it's benign. It's nothing to worry about. It's just mature fat cells. It's a yellowish mass surrounded by a thin layer of epithelium. In the oral cavity, the most common place to see this is on the buccal mucosa, and then like the picture you see here, it's down in the vestibule. It occurs in individuals over the age of 40 usually. And if we looked at it microscopically, it's just a well-outlined tumor. It's usually pretty uniform in shape, and a lot of times they can just go in and excise that and get the whole thing. The tumors of nerve tissue are the neurofibroma and schwannoma, granular cell tumor, and congenital epulus. The neurofibroma and schwannoma are benign tumors derived from those Schwann cells you guys have learned about in nerve tissue. The tongue, as we know, is highly innervated, so it is the most common intraoral location. This can occur at any age, and it's commonly seen in patients that have neurofibromatosis of von Recklinghausen syndrome, which we'll talk about more. The neurofibroma is well delineated. It has kind of a diffuse proliferation of spindle-shaped Schwann cells, which you can see in that slide. A schwannoma is spindle-shaped Schwann cells arranged in these little whorls. So they can differentiate between the two by microscopic evaluation. And to treat these, we're going to surgically excise them. A granular cell tumor is benign. It's composed of large cells with a granular cytoplasm. These most commonly occur on the tongue, and then next most common is the buccal mucosa. Usually these are painless. They're non-ulcerated, and it's just a little nodule that we might feel. If we're doing like a intraoral exam and feeling the tongue, you would feel like a little bump. Most found in adults, with females being more common. They think it arises from neural or primitive mesenchymal cells, and treatment is removal. Congenital epulus. Congenital, remember congenital means I'm born with it. So this is a benign neoplasm composed of cells that look like the granular cell tumor that we just saw. Most likely, they think it arises from primitive mesenchymal cells. It can appear as a sessile or pedunculated mass on the gingiva. Usually occurs in the anterior maxillary gingiva, and it almost always occurs in baby girls, and surgical excision is treatment. I'm wondering if they have a picture of that in the book. I don't see it, but typically, since you're born with it, usually you're going to see a picture of a baby, and up on that maxillary alveolar ridge, they're going to have this little growth right there. And that's what the congenital epulus looks like. So tumors of muscle, these are extremely uncommon in the oral cavity. We see either vascular leiomyomas, those would be the rhabdomyoma or the leiomyoma. One is striated, so rhabdo is the prefix for striated muscle, and then leo or lyo is the smooth muscle prefix. Rhabdomyosarcoma is very deadly. It is a malignant tumor of striated muscle. It is the most common malignant soft tissue tumor of head and neck in children. And unfortunately, there was a little boy in Kearney that had this, and he was about 8 years old, and he was gone within the year. It's very rapidly progressive, and it's very destructive, and it has a very poor prognosis. And it's horrible. The growths that you see from this condition are horrible. So typically we're going to see this in little boys, ages 10 and under, and again, very rapid growing. They treat it with multi-drug chemotherapy, radiation, and surgery, but again, it is a poor prognosis. Vascular tumors that we're going to touch on are the hemangioma, the lymphangioma, and malignant vascular tissue, or vascular tumors, sorry. Hemangioma looks like a blood blister basically, and what it is a benign proliferation of capillaries. If we see a capillary hemangioma, that contains numerous small capillaries. And then cavernous, if you think cavern, it's large. So this contains large blood vessels. If you see a cavernous hemangioma, it's going to be much larger than a capillary. These are most often present at birth or will arise shortly after. More than half occur in the head and neck area, and the tongue is a most common intraoral location. We see these more in females, and they may occur in adults as a response to trauma, like a blood blister kind of. And when you apply pressure, they'll blanch. I don't know if you've ever seen, I believe if you look on page 240, there's an infant there with two red hemangiomas. Sometimes people will call them strawberries, and babies will be born with those, and usually as they get a little bit older, they'll go away on their own. I had two nephews that had pretty good sized ones that went away with time. Treatment, they may undergo spontaneous remission. They can you do surgery with the injection of a sclerosing solution, which a sclerosing solution just makes something kind of harden so that they're able to remove it. A lymphangioma is a benign tumor of lymphatic vessels. Most are present at birth. Half of them are in the head and neck area. And intraorally, the most common location is going to be on the tongue. And it is an ill-defined mass with a pebbly surface. I don't see one here to show you. Okay. Treatment is going to be excision, and these do tend to reoccur. Malignant vascular tumors. We've heard of the Kaposi sarcoma. That is a malignant vascular tumor, and there is also an angiosarcoma. This one is rare. But the Kaposi sarcoma is the one that we see associated with HIV. These can arise in multiple sites, including the skin and oral mucosa, and it's historically seen in men. Lesions in HIV are in the oral cavity are seen as that really dark purple, sometimes almost black macules or plaques, and sometimes they can even be exophytic or stick out. Most commonly located on the hard palate and the gingiva. It can also occur in patients with other forms of immunodeficiency. It is caused by a human herpesvirus HHV8, which is also called Kaposi sarcoma associated herpes virus. So HH8 or HHV8 is the herpes virus that is associated with these Kaposi sarcoma tumors. And what do we do for them? They excise them, they treat them with radiation therapy or both. Tumors of melanin-producing cells are the melanotic nevi and the malignant melanoma. And remember I said melanoma is a bad deal. So melanotic nevus or nevi is a single, is just a flat, dark lesion. They're usually more sessile. They are due to the melanocytes that multiply, and a lot of times we're born with this. It can arise on the skin or oral mucosa. Intraoral tumors can consist of a tan to brown color, and they most often occur on hard palate or buccal mucosa. These are more common in women and usually first identified in individuals between 20 to 50 years old. Most are benign. We would always have them checked to rule out a malignancy. Treatment is biopsy and then surgical excision, and again, recurrence with the melanotic nevi is rare. Malignant melanoma is a malignant tumor of melanocytes. Melanocytes are the cells that create the melanin or the pigment in our skin. Most of these arise on the skin in response to prolonged exposure to sunlight. A primary lesion is rare, but melanomas on the skin may metastasize to the oral cavity. Usually it is a rapidly enlarging blue to black mass. They look evil. It is a very aggressive tumor, and it has very unpredictable behavior, and it usually metastasizes early. So by the time you see it, it's not typically a primary lesion in the mouth. Normally, if we see something in the mouth, the primary lesion of melanoma started somewhere else and has shown up in the mouth. By the time we see it, it could be pretty far advanced. The most common intraoral locations are the palate and maxillary gingiva. Usually occurs in adults over 40 years of age, and treatment is going to be surgical excision. Chemotherapy can be used along with surgery, and it is a poor prognosis. Tumors of bone and cartilage. Osteo is the prefix for bone. Chondro is the prefix for cartilage. So if you see chondro, that is going to indicate that we're dealing with cartilaginous tissue. So an osteoma is benign. So this is an asymptomatic benign tumor composed of benign compact bone. And if it's bone, it's going to be radiopaque. So it's going to appear as either a sharply delineated or outlined radiopaque mass within the bone, or it can also be attached to the outer surface of the bone. We see these osteomas with Gardner syndrome. So Gardner syndrome is a syndrome that can develop malignant colorectal tumors. So if we see these osteomas, sometimes we could help diagnose this condition before they got to the point where those tumors were cancerous. So osteomas are often seen in that. If they have an osteoma, it doesn't necessarily mean they have that, because with Gardner syndrome, we see multiple osteomas. And you can see here it is the radiopaque mass that is attached to the bone on the lower left in that image. Osteosarcoma has also been called osteogenic sarcoma, but osteosarcoma is what you're going to hear more common, I think. This is a malignant tumor of bone-forming tissue. It is the most common primary malignant tumor of bone in patients under the age of 40. The average age is going to, if it's involving their jaw, is about 37 years old. And this one occurs twice as often in the mandible, and it is more common in males. It varies from radiolucent to radiopaque. It is usually destructive, poorly defined lesion. It may or may not involve soft tissue, but it is known, you want to remember this, by its sunburst pattern. So if you look at it, it kind of looks like a sunburst. This image I don't think looks as sunbursty as some, but you can see the radiopaque lesion up in the upper right corner there. Treatment is going to be preoperative multi-agent chemotherapy with surgery, and then unfortunately these frequently reoccur. The tumors of cartilage are chondroma, which is benign, and chondrosarcoma, which is the malignant form of the cartilaginous tumor. These are going to be treated with wide surgical excision, and typically these have a poor prognosis. And this one is seen on page 243, and that is a chondrosarcoma. So that is malignant, and it is an exophytic mass in the anterior mandible there. The tumors of blood-forming tissue are leukemia, lymphoma, and multiple myeloma. Leukemia is a broad group of disorders characterized by it's an overproduction of atypical or abnormal white blood cells. They can be mature, they can be immature. The mature ones are usually oddly shaped. The immature ones are just immature, and they don't get to the point we need them to be, and they don't do their job like they're supposed to. So there's different types of leukemia that are classified according to the kinds of cells that are proliferating or that are multiplying. The myelocytes, the lymphocytes, or the monocytes. Acute leukemia is most common in children and young adults. So this is acute is quick onset. It's characterized by that proliferation of immature white blood cells. Chronic leukemia is going to occur more often in middle-aged adults and characterized by an excess proliferation of mature white blood cells. The acute leukemia is quick onset, worse prognosis. Chronic leukemia, if it has the opportunity to be chronic and ongoing, it's going to be a better prognosis. It takes longer for it to reach those horrible levels. Acute leukemia comes on quick and can cause problems quick. So treatment for leukemia is going to be chemotherapy, radiation therapy, and corticosteroids. And then again, prognosis depends on the type and the extent of the disease. So it's just going to depend what kind of leukemia that patient has and how far along it was when we caught it. Lymphoma, you've probably heard of Hodgkin's lymphoma or non-Hodgkin lymphoma. Lymphoma is the one that I told you is another oma that is malignant, and it is a malignant tumor of lymphoid tissue. What we see clinically is a gradual enlargement of their lymph nodes. So this is why we do our extraoral exams. We want to feel and measure and note where we are today so that when we see them in 3 months or 6 months, if we see enlargement or changes, we can note that. Maddie, is your mom okay? Madison Oldham said that her mom had non-Hodgkin's. So the most common intraoral location in this is the tonsils, and it occurs in adults. We see this more in men than females. Radiotherapy, surgery, chemotherapy, or a combination of all of those therapies are typically used to treat this. Whoops, sorry. Multiple myeloma. We have a patient with this, and this is a proliferation of plasma cells. This is not a very good outcome. It's very destructive. It causes destructive lesions in the bone. They call it moth-eaten. So if you were to look at their skull, there's holes. You can see like holes in the skull where it has destroyed the bone. Most of these patients are older than 40. Our patient, I think, was 60 or 70, like late 60s. And it was a female, and they say males are affected more. And they usually experience pain, and she was experiencing a lot of pain. Madison said that her mom is cancer-free now, and she was diagnosed right after Maddie was born, so that's good news. So that was with the non-Hodgkin's lymphoma. Okay, so radiographically, like I said, lots of little radiolucent lesions. As far as the mouth and jaw go, the mandible is affected more often than the maxilla. Most patients have an elevation in a single type of immunoglobulin, which is how they can test for this. And they call that a monoclonal spike in that specific immunoglobulin. They also have fragments of these immunoglobulins in their urine, and that is known as Bence-Jones protein, so they can do a urinalysis as well. An extramedullary plasmacytoma is a localized tumor of plasma cells in the soft tissue that we sometimes see with these patients as well. Their treatment is going to be chemotherapy, radiation, and prognosis, unfortunately, is poor. Metastatic tumors from primary sites elsewhere in the body are rare. So most tumors will arise either from thyroid, breast, lung, prostate, and kidneys. The most frequent intraoral site for a metastatic tumor is the mandible. Metastatic meaning that these tumors, like it says, the primary site was somewhere else. So like, let's say that I had melanoma, God forbid, and I had a lesion on my leg that I hadn't really paid much attention to, and it went unnoticed or untreated, and now they're finding something in my mouth. By the time they're finding an oral lesion, the tumor that was the primary site, that would probably tell me that my cancer is pretty far along. So that's not always the case because some cancers move along quicker than others. But when there's talking about a metastatic tumor from a primary site, that means that that started somewhere else. The most frequent intraoral site for metastatic tumor is the mandible. So maybe it started somewhere else and it's now seen in the mandible. Typically, patients experience pain, paresthesia or anesthesia of the lip, possible swelling and expansion of the affected bone, possibly even loosening of the affected teeth. Most patients are adults, and males are affected more often than females. Radiographically, these lesions are usually poorly defined and radiolucent. The roots of the involved teeth may show kind of a spiky appearance. If tumors form bone, they can become more radiopaque. And again, with these, we're going to treat them with chemo and radiation. Prognosis for patients with tumors that have metastasized to the jaw from somewhere else are poor because, like I stated with the melanoma example, by the time it has metastasized there, it's been somewhere else, and it's probably pretty far along. And here is an example of a jaw. As you can see, there's lots of damage there. We don't have teeth anymore either. So it metastasized to that area. Okay. I'm stopping my recording.